Let's jump right into this rapid-fire explanator on dermatological oncology clinical cases.
A 37-year-old male presents with an erythematous, scaly, and fissured back lesion with irregular margins that's been there for 10 months. The biopsy highlights altered Malpighian cells and atypical cells. What's your probable diagnosis?
The correct answer is E, Bowen's disease. This is essentially an in situ squamous cell carcinoma. The atypical keratinocytes span the entire epidermis, but, and this is absolutely crucial, the basement membrane remains completely intact. If you look at the histology, you'll see a classic wind-blown appearance, which is just driven by a total loss of cellular polarity. Your massive exam pearl to take away here is the treatment, a wide surgical excision with a standard 4mm margin.
A 60-year-old female presents with a 3 by 3 centimeter ulcer on the lower outer edge of her right eye, accompanied by hard, palpable regional lymph nodes. What is the clinical diagnosis?
If you guessed A, squamous cell carcinoma, you nailed it. The crucial pearl to remember is the metastasis rule. Basal cell carcinomas practically never spread to regional nodes, so the fact that we have hard, palpable lymph nodes heavily points to SCC lymphatic dissemination. Keep in mind that roughly 2/3 of enlarged nodes in this specific setting are true tumor macrometastases.
A patient presents with a rapidly expanding 3 by 6 centimeter scalp nodule with everted edges and erythematous tissue that grew over just a few weeks. It features a distinct central crater-like keratin pearl with absolutely zero lymphadenopathy. What is the probable diagnosis?
That's going to be C, keratoacanthoma. This solitary dome-shaped nodule is a notorious clinical lookalike to well-differentiated SCC. It's totally characterized by that rapid growth over a few weeks and the pathognomonic central keratotic plug. Because it looks histologically almost identical to a highly aggressive SCC, standard management dictates you do a complete excisional biopsy just to be safe.
A 50-year-old patient presents with a facial ulcer that's been there for a year following historical trauma. It features on and off bleeding, alongside palpable submandibular and prearcular lymph nodes. What is the probable diagnosis?
The answer is D, squamous cell carcinoma. Whenever you see historical trauma combined with palpable regional nodes, it's highly indicative of invasive SCC. You've got to remember the core predisposing risk factors for cutaneous SCC here: chronic non-healing wounds, UV radiation, immunosuppression, and high-risk HPV strains 5 and 16.
A 39-year-old male presents with a non-healing forearm ulcer following trauma a few months prior. The physical exam reveals that the edges of the ulcer are distinctly turned out or everted. What is the probable diagnosis?
Again, the correct answer is D, squamous cell carcinoma. Those everted margins are really classic defining physical sign of malignant squamous epithelium. What's literally happening here is the malignancy is invading lateral tissue planes, actively pushing the edges of the wound upward and outward.
A 45-year-old female presents with a 12-year history of a hypertrophic scar from a kitchen stove burn. Recently, an ulcer developed inside the scar, mutating into a cauliflower-like mass. What's your diagnosis?
The answer is A, squamous cell carcinoma. This is the textbook clinical footprint of a Marjolins ulcer. It's an aggressive SCC that pops up after a really long latency period, often spanning decades, within historic unstable burn scars. It carries a notoriously high rate of early regional and systemic metastases, which means prevention relies entirely on getting in there early and surgically excising unstable scars.
How much surgical clearance margin should be achieved for a squamous cell carcinoma with a clinical surface size of less than 2 centimeters?
The correct answer is B, 4 millimeters. For a low-risk SCC under 2 centimeters, you need exactly a 4mm surgical clearance margin. But if you're dealing with high-risk tumors larger than 2 centimeters, that requirement totally expands to a 10mm or 1 centimeter clearance margin, taking it all the way down to the deep fascia.
A 57-year-old presents with a long-standing 2 by 2 centimeter temporal ulcer that periodically crusts and bleeds. The margins are raised and rolled, but there's no regional lymphadenopathy. What is the probable diagnosis?
The correct diagnosis is B, basal cell carcinoma. Let's compare the physical presentations real quick. Basal cell carcinoma features these smooth, rounded, rolled-in pearly edges, often with central ischemic necrosis and fine telangiectasias. This is a sharp contrast to squamous cell carcinoma, which gives you those sharp, ragged, heaped up, and everted borders we talked about earlier.
A 55-year-old fair-skinned female presents with a non-healing ulcer located directly at the inner canthus of the right eye. It has rolled margins and no regional lymphadenopathy.
What is the probable clinical diagnosis?
The answer is C, basal cell carcinoma. The critical exam pearl here is the specific anatomical location. The inner canthus sits dangerously inside the high-risk facial H-zone. Tumors sitting right over these embryonic facial fusion lines can aggressively track down into deep structures, which carries an intense risk of orbital or even intracranial extension if neglected.
Most micrographic surgery is the preferred mode of treatment when basal cell carcinoma is located in which of the following locations?
The answer is D, the medial canthus. Mohs micrographic surgery is absolutely the go-to for high-risk sites because it maximizes healthy tissue preservation around really critical structures. It maps 100% of the surgical margin microscopically in real time using sequential frozen sections, giving it a massive 98% cure rate for primary lesions.
Which of the following is the single most common anatomical site for basal cell carcinoma to develop? It's D, the nose. Roughly 85 to 90% of all basal cell carcinomas happen on the sun-exposed skin of the head and neck. And the nose is the primary target by far, accounting for about 25.5% of all subsites, mostly happening above an imaginary line you draw from the angle of the mouth right to the earlobe.
A middle-aged patient presents with destruction of the nail bed and off and on bleeding. The history reveals a linear, pigmented band along the length of the nail that widened progressively. What is the most common macroscopic variant of malignant melanoma overall?
The correct answer is A, superficial spreading melanoma. This specific variant alone accounts for about 70% of all melanoma cases. It's characterized by a really prolonged microscopic horizontal and radial growth phase, which unfortunately allows it to escape clinical detection before it eventually evolves into vertical invasion. So the real question this leaves us with is, how do we get better at catching these silent horizontal changes before they become massive vertical oncological challenges?